for the fellows that are here, thanks for coming. Hopefully we'll have some more people get on as we get going here. Tonight we're going to talk about distal femur fractures, tactics for escalating complexity. If we want to welcome you to the North America Fellows webinar series, we want you to be involved. You know, AO North America is all about camaraderie. We want to help develop you as an educator and kind of develop a network of peers through AO North America. So this webinar series for the fellows is always on Wednesday. It's at 8 o'clock Eastern. It's a 4-year curriculum and we have 6 topics per year. So we always spend time talking about pelvis, acetabulum, femur, pilon, lower extremity deformity, bone defects, nonunions, all the cool stuff that fellows want to talk about. So upcoming that we have this year in September, on the 15th, we're going to talk about the scapula and glenoid. On October 13th, acetabulum. We're going to talk about radiology and fracture types. And then on November 10th, bone defects, nonunions, and osteomyelitis for trauma surgeons. Disclosure slide for this particular talk. I'll let you look at that as long as you like. Overview for our talk tonight. So this webinar is going to address different techniques for the operative fixation of distal femur fractures, managing bone defects, as well as non-union / complication management. So we'll have an interactive session at the very end where we predict union or failure, and you'll have an opportunity to voice your or to give your vote whether you think the presented fracture is going to heal or not. So at the conclusion of the webinar, participants should be able to identify options available for managing distal femur fractures, recognize the implications of reduction in stability and how it is related to common failure mechanisms, and describe various ways implants can be used to affect your stability, healing, and complications. So basically, the outline of tonight is the introduction that you're getting right now, which is going to be short, 3 amazing talks that are about 15 minutes in length, and then this rapid fire heal versus fail, where you will all vote and the faculty will kind of give their 2 cents as well. First, we're going to have Mara Schenker. She's going to talk about her evolution in management of distal femur fractures, her first 5, or I think it's now 6 years in practice. Then we'll listen to Justin Holler talk about distal femur fractures with bone loss and how to manage defects. And then Sean Nork's going to talk about the management of complications after distal femur fractures. And without further ado, we're going to get started with our first talk and dive right into it. So Mara, I think you're up first.
Yep. Hi, everybody. Let me share my screen. My name is Mara Schenker. I am the Chief Orthopaedics for Grady Memorial Hospital. And so there's really not been a fracture pattern that I have changed my thoughts and practice on more than I have distal femur fractures in my first 6 years in practice. And so I sort of wanted to walk you through what my thoughts were as I started and now have, you know, drank from the fire hose over the last 6 years. And so when you first start practice, you know, there's no joke, starting practice is very difficult. And part of that was, you know, this is what I walked into. So major level 1 trauma center, really bad injuries, but really the majority of it is you have a very small toolbox. And so even though you've had excellent training, you know, I always go into cases now with A, B, and C options in case A and B don't work. Well, at the time when you first start practice, you don't necessarily have those options. And so when I was first looking at distal femur fractures, really my main approach to this was the use of the distal femoral locking plate. And over the last 6 years, my toolbox has grown. And so now I have lots of options. So, you know, extreme nailing, dual plating, distal femoral locking plate, and then plate nails. And so I'm going to go through sort of what my thoughts were, where I started, and how I got to where I am now. And so no longer hiding from these. But so this is somebody who came in, 64-year-old female after a motor vehicle collision, had bilateral distal femur fractures, pulmonary contusions, and she came in on day 11 of my clinical practice. And so this was her left side. So you have a comminuted metaphysis of the distal femur with what looks to be a simple articular split, which was confirmed on the CT scan on the bottom right. The right side, same thing. So this is a highly comminuted metaphysis with a split that extended into the intercondylar notch, and then also had a comminuted tibial plateau fracture. So this is both sides. She's sick. Pulmonary contusions, was in the ICU. And so we have our first polling question. So definitive surgical options. So distal femoral locking plate, dual plating, plate nail with a pre-contoured plate nail with a small frag plate, extreme nailing, or distal femoral replacement. So I'm going to let you guys vote for just a second. And this is for both. So I'm assuming they're both very similar injuries, which they are. Okay, so distal femoral locking plate. That is the most common response at 62%, with a few folks saying plate nail and a few folks saying extreme nailing. So between, when you add the two up, it's really 50-50. So some sort of nail and then just over half saying distal femoral locking plate. And so first day she came in, she was pretty sick. We X6 both sides. I probably would still do that to this day. But then she got this. So this is hospital day 6, brought her back, assuming that's when she stabilized from a physiologic standpoint. She got open adductor fixation of the distal femur and proximal tibia on the left side. And then hospital day 15, she got ORIF of the left distal femur. And so that's the left side. And so when I'm taking a critical look at this, and I encourage you to go back and take very critical looks at your early fixation strategies. And so I look at this and I'm like, okay, it's in a little bit of valgus, it's in a little bit of extension on the right side. And then on the left side, there's clearly something going on, probably from a rotational standpoint. The sagittal plane alignment looks good, but there's just something about that coronal plane alignment that I'm a little bit unsure of. But that, you know, every time I've done these, I go back and I critically look at these. And so what do I see now that I didn't see then? And so this to me is primarily a metaphyseal injury now. And the interarticular component of this is relatively insignificant. So then I ask myself, okay, the primary issue is the metaphysis. What does this want? And the answer to that to me is a nail now. And how do I work that articular fixation around that? And so she was a bilateral injury with pulmonary contusion. So in addition to it being primarily a metaphyseal injury, this is also somebody that now with distal femoral locking plates, I'm going to keep off of both sides. And so I'm also thinking about her overall resuscitation and wanting to get her up weight bearing. And so I may not let her weight bear on that right side, obviously, because of her tibial plateau, but if I can even let her use her left leg for transfers, that's going to help with her overall recovery. And so those are the two thoughts going into my head that I didn't necessarily recognize back then. So this is somebody I did a little bit more recently. So this is a 59-year-old male, status post assault. Again, same thing, comminuted metaphysis, probably a little bit more of a complex articular involvement. This is his CT scan through the joint. Okay, so a little bit more articular involvement than the last one. And so what are your definitive surgical options for this guy? So same options as before in the same order. Okay. So folks still saying distal femoral locking plate. I absolutely don't disagree. And part of the gem of this talk is this is a lot of level 5 evidence based on my own clinical practice. And so it's absolutely an option. Some folks are saying dual plating, plate nail, extreme nailing, 15%. And so for me, same thing as before. This is primarily a metaphyseal injury, and so this one's a nail. I don't think, plate nail would be a wrong answer, but in my hands for this one got an extreme nail, so a bunch of articular fixation with a retrograde nail. And so for this is somebody who I now let weight bear at a much earlier time frame than if I put a distal femoral locking plate on. And the other gem from this is I treat the metaphysis when the metaphysis needs to be treated with a nail. So Switching from the primary metaphyseal injuries. So this is a 74-year-old guy who runs 4 miles a day. He was judging at a track and field event, looked up into the sun, didn't see a hammer coming his way, and he got smacked in the knee with a hammer throw at a track and field event. And so this was his comminuted intra-articular displaced distal femur fracture. And so this is his axial scan. So it's as expected. You've displaced condyles, not that bad of an articular injury, just more displacement than anything. And this is his coronal. So definitive surgical options for this guy. Same options as before. So distal femoral locking plate, dual plating, plate nail, extreme nailing, or distal femoral replacement. Again, there's no right or wrong answer to these. It's just sort of what my thoughts are. Okay, so these are a little bit more split, 53%, so still about half love the distal femoral locking plate, 18% say dual plating, 12% plate nail, and 12% extreme nail. So that's what he got. To me, this was just a bunch of simple fracture patterns. And so it was amenable to lag fixation and neutralization plates. So we lagged across the joint surface with some 3-5 screws, and we lagged across the lateral condyle component, and then neutralized with that distal femoral locking plate. And so this was, again, relatively early, but anatomically looks good. I'm sorry. So this is what he looked like at 6 weeks, 3 months, and 6 months. And so you can see that this is not what I was expecting from a distal femur fracture where I fixed it with absolute stability and primary bone healing, because he formed a robust callus there. And so then the question that ran through my mind is, why did he form that callus, and why did he try to fail when this looked so anatomically reduced? And so what do I see now that I didn't see then? And so he had a very displaced medial femoral condyle. And even with the best reduction that I have, I'm holding on to that medial femoral condyle like somebody standing at the end of the diving board with that distal femoral locking plate, and it just really doesn't want to stay. That plus he did have a little bit of comminution on the medial side. And so, why did that lead to potentially the early, and that's the last set of x-rays that I have on this guy, but he's back to running. But so yes, maybe he healed, but he certainly tried to fail. And the question is why? And so I asked myself when I looked at this, I'm like, if this was a tibial plateau fracture that's upside down, would I fix a displaced bicondylar plateau where you have that much displacement on the medial side with just a single locked lateral plate? And the answer to that, at least in my hands, is no. And so then to me, I'm like, well, if you've got a simple pattern on that medial side with that much displacement, does that need dual plating? And so that's my question. So this is somebody who I did actually last week. This is a 57-year-old female, status post-motor fecal collision. She had a tibial plateau, open reductional fixation 20 years ago. Also has a total hip on that side. So this is her axial CT scan. It's much more comminuted than it actually looks on that initial side, particularly in the lateral femoral condyle, because she drove that plate likely through part of her distal femur. So options for her. Same options as before, but knowing what I learned before, this changed my approach to this one. Okay. All right, so about half said dual plating. So I like where your mind's at. So now what I do is I think twice about that displaced medial femoral condyle, and she got dual plating, where maybe a distal femoral replacement in somebody who didn't have a long stemmed total hip prosthesis would have been a good option. But in this case, it wasn't. So I opted for a fixation with dual plating. And so what I've learned in this last 6 years, and this is again my own level 5 evidence, but distal femoral locking plate, I do a lot less now in isolation. This is one I did not that long ago, but has a comminuted metaphysis with a total knee and a total hip. So an interprosthetic fracture with somebody who I've this was open to, just did a distal femoral locking plate. My thoughts on dual plating are when you have displaced simple medial femoral condyle involvement. Basically, if I would flip it upside down and I would dual plate it, if it was a tibial plateau, I have been doing the same thing for the distal femur. So plate nail, so a true plate nail where you have mating of the nail and you have with a plate where it spans the entire, both the plate and the nail span the length of the bone is really something that I use in geriatric fractures and is something that I do immediately allow to weight bear. So this is one that I did not that long ago who had a lot of underlying medical disease, and I wanted her to be able to mobilize as quickly as possible. And so that's when I use the true plate nail combo. Plate nail with small frag plates is when it helps with alignment for extreme nailing. And so in this case, there was a good read along that medial side, and I'll use a small frag plate to help with the reduction, and then then do a quote unquote extreme nail. Extreme nailing, so that's whenever it's possible with some simple articular splits, and it allows me to weight bear people earlier than if I was just putting a single locked lateral implant. And then distal femoral replacement is really just reserved. And we probably at most do one of these a year, Grady, but is comminuted intra-articular geriatric fractures, but again, very rare. So this all sort of puts together to help take care of these patients. So this was a 55-year-old guy, pedestrian versus auto, has obviously a comminuted intra-articular distal femur with a like pertroke that extended into the neck on that ipsilateral side. And this is what he got. He got a whole lot of metal in his leg, but went on to union at 18 months. So thank you very much.
Thank you. So we'll have Mara stop sharing and Justin will share. Just for the participants, there is a little Q&A box down there on the bottom of the screen. When you move, you can see the Q&A. And you're welcome to type questions in there. We can try to answer questions on the fly as we're going if you like. Okay, take it away, Justin.
Okay. All right, thanks. So Justin Heller at the University of Utah. I get the opportunity to talk about distal femoral bone loss and kind of what to do about it. So objectives for this talk are identifying kind of what is bone loss in the distal femur that may require grafting, a little bit along what Mark use multiple implants, some of the different bone graft options that we have to address the bone loss in the distal femur, and maybe some potential adjuncts for people we identify as poor bone healers. So what exactly is bone loss in the distal femur? There's not a whole lot out there to really guide us. And I think this is one of the more challenging aspects of managing these, is when they actually might heal on their own versus when they need some kind of grafting. And so it's reported that up to the defects up to 15 centimeters can heal spontaneously. I think this is more for a femur fracture. And I think this is, even though it's reported 15 centimeters, it seems a little extreme. There is an article that's here by Dr. Bray and Beingester out of Harborview that suggests fractures with bone loss that have some posterior or medial cortical contact are associated with healing and may not require a bone graft. I think patient factors that we need to look at are whether it's an open fracture or not. Most of these, by and large, are going to have are going to be what we see with bone loss. But there's a case I'll show in a little bit where it's not an open fracture, but there's some associated bone loss. Certainly age and osteoporosis and some other things associated with poor healing that may drive us towards addressing these injuries with a approach toward using bone graft. All right, so to run through some cases, this is a 50-year-old guy who was skiing early in the season. He didn't see a rock and just fell and hit a rock and had a kind of 3 centimeter open distal femur fracture. He's otherwise healthy. He also has an ipsilateral closed tibia fracture, but otherwise pretty isolated. And these are his injury films showing a fairly comminuted metaphyseal injury with intra-articular extension. And then kind of going through his CT scan, you can see that, again, he's got a fair amount of metaphyseal comminution with a simple articular split and a fairly non-displaced Hoffa fragment there. And then looking at the 3D reconstruction, give you an overall sense of what's going on in his distal femur fracture. And so after a thorough IND, I mean, he does have some bone loss. This is what we did intraoperatively, where we used this small frag plate to help us with a large cortical fragment laterally, and left the medial and posterior metaphyseal segments alone since they had some muscle attachment. Figured these were vascularized, and given the study by Dr. Beret and Beingester, we thought this sort of a reasonable chance to heal. And we obviously fixed his joint with those lag screws. So he unfortunately followed up elsewhere. We do have some films on him at 5 months, where it does look like he's has some healing along the medial and posterior aspects of his femur. However, at the outside institution, he underwent a non-union surgery where he had some of his hardware and his plate removed and had this retrograde nail placed. Unsure whether he had bone graft placed. I got to assume he was having symptoms at the time of around 6 months, and the treating surgeon felt it was necessary to take him for a non-union procedure. And so hopefully the learning points of this case, at least for me, are that to listen to patient symptoms, even though he had some radiographic healing, that suggests he might make it in terms of from his original operation. If patients having pain at all, it's a much easier operation and easier patient recovery just to take them for non-union surgery while the implants are still intact. And I think it just goes to show that even though this is a healthy guy with good medial and posterior cortical contact, that you can obviously still have a non-union develop. So next case is this 17-year-old female. She was involved in a head-on MVC where she had a 3A open femur fracture that was initially spanned an outside facility where they did an IND as well and removed some bone. She also had a contralateral tibia and contralateral femur fracture that are fixed like this. And so here are her CT scans that show fairly complex metaphyseal injury with some bone loss. But overall, her distal femur is not too bad. She does have that articular lesion on the lateral aspect. And then again, the 3D recon just to give an overall sense of the amount of comminution. She also has that patella fracture that may change your management. And so for her, I think the next step for me for this lady was to do a gun-site CT scan, since we use the contralateral femur to help us with length alignment rotation. To me, her presenting radiographs were a little concerning for a malrotation. Even though they're a little bit of an obliquogram, it was concerning enough to me to get a gun-site CT. Looking at that, she had about 30 degrees of anaversion of her left femur. We don't know what normal is for her, but since we're using, at least I was planning to use that left femur for a guide for her rotation on the right side, it was important to get her in the realm of normal. And so the other thing that I thought made it seem abnormal for her is the cross section of her distal femur, where you can see her patella looks like it wants to subluxate a little bit. And so what we decided to do was first revise her left femur where we took about 20 degrees of rotation out, and to get a better assessment of her length and rotation of her less complex side, which is demonstrated here in the fluoro spots. And then we proceeded to use a lateral lock plate on her femoral side with bone loss, where again, we used the ruler to get an idea of what her length was after establishing the distal femoral plate on, and then achieving the length that was about right and confirming her rotation compared to the contralateral side. I think this would be a great case for a retrograde nail. The reason I elected to use a locked lateral plate is I was concerned about that lateral femoral condyle. It was fairly close to our start site and didn't want to make a starting hole that close and just have a big aperture on the distal femur and lose control of the distal femoral segment. So that's why she got this as opposed to a retrograde nail, which would have been a great option. So these are what her post-ops look like. Given the amount of open injury and some of the devitalized bone that was left in there by the outside treating surgeon, I felt like this was unlikely to heal on its own. So we did an induced membrane technique where she got a cement spacer. In critiquing my final x-rays, we certainly could have expanded the cement a little bit more proximal, a little more distal to have some overlapping coverage over the intact bone. Then elected to, at 8 weeks, take her back and remove the cement block. And we had to incorporate multiple bone graft sources given the extent of her bone loss. Where we used some iliac crest coracocancellous strips, some proximal tibial graft, and some graft extender. If you remember back, she had her contralateral femur had a nail, contralateral tibial had a nail. We could have certainly used other areas on her crest, like posterior crest or something like that. But I've had good success with the coracocancellous strips where they were placed inside, and it looks something like this. And so at 3 months post-op, these are her radiographs. She has some callus formation. Her range of motion is progressing to about 90. She's able to walk without an assistive device. And we get these people moving or weight bearing fairly early after grafting them. At least that's what I do in order to hopefully help with callus formation. And so this is her at 12 months where she has full range of motion. She's able to ambulate fairly normally, and she wants to know when she can get back to skiing. And so I think the learning points for me on this case are with these femurs and with bone loss, you may not have a good idea of their length, alignment, rotation, and to use the contralateral side. For her, this is kind of a good example of that can be challenging if there's an injury on the contralateral side. And so I think discussing your plan and your concerns about length, alignment, rotation go a long way with the patient. And they like to know early on that that's a concern, and it makes you look like a good doctor that you're considering it. Also for ones like this where it's a large defect, consider multiple bone grafting options. And the fact that she had some nails in the other long bones makes it hard to use RIA. And so considering pelvis and proximal tibia is the way to go. And I think this highlights the healing capacity of young patients versus old patients, which will show a couple old patients that have been troublesome for me. But something to consider when you're thinking about what to do for these patients. Next case is a case of a 65-year-old female, where it was a car versus semi. These are outside presenting films where she has a pretty complex distal femur fracture with bone loss. This is a 3 open injury over her distal femur. And then she also has this femoral neck fracture that's ipsilateral. And so here's a look at her CT scan that confirms the amount of distal femoral bone loss in the metaphysis. Also on the axial slices, you see the extent of her articular injury. And so she was initially fixed outside, and they did a really nice job on her femoral neck. Not so pleased with the distal femoral fixation. They actually bent the plate for some reason and translated her distal femur medially. But props to the outside treating surgeons who realized that this is not acceptable and referred her for revision fixation. So that some floral spots of what we did, obviously took everything out, started with the articular block with reconstructing that with a bunch of mini frag fixation. She got dual approaches with a proximal humerus plate on the medial side and a locked distal femoral plate on the lateral side. And again, given her defect, we placed some cement for an induced membrane technique. Here are her final floor spots, which hopefully demonstrate a good articular reduction and her graft. And I shorted the plate a little bit so it wasn't so close to her screws proximally, just so it wouldn't create a stress riser for her. And so we elected to graft her with at around 6 weeks when her wounds were healed. For this one, we used contralateral femoral rhea. And I used this femoral or fibula allograft strut that was placed intramedullary just as mainly a space filler, given the amount of distal void in her metaphysis, just so that we wouldn't need as much rhea grafting. Usually when you do a rhea, it heals from outside in. So this is a nice way to hopefully fill up the void so long as you don't get a infection, which can be a disaster. And so we had her weight bearing at 12 weeks from her original revision operation. Unfortunately, around 12 months, she's one of these elderly patients that are not good bone healers. And I don't know if you can appreciate, she's broken all her screws on the medial side, and she's also broken all her screws on the lateral side. She does have some pretty good bone healing, but obviously hasn't finished the job, given that she's broken all of her implants. And so I felt this was related to the amount of overall stiffness in her construct, given that I had to have a shorter plate than I would normally like to on the lateral side, and given that she's got dual plates. And so what we did was we left her medial plate, given that everything was broken on the medial side. I felt like what we really needed was some flexibility in regrafting. So we changed out her lateral plate and regrafted along the lateral aspect of that fibula allograft. And so the x-ray to the right is her at 2 to 3 months, where she's got increased healing on the lateral aspect. And then she recently got a CT scan that's like 4.5 months out that shows she's starting to heal her the lateral aspect of her femur. So for me, the learning points on this one are hopefully to consider fibula strut allograft in cases where you have big voids, and to hopefully fill the central area and allow for distribution of the graft peripherally. I think either a medial plate or IM nail for early stability can be helpful in these elderly patients that are going to take a long time to heal. And it's important to consider your construct rigidity for these defects, where we want some relative stability to encourage the callus formation where we place our graft. All right, so last case is this 71-year-old female. She had a ground level fall, fairly simple interprosthetic fracture. She's otherwise fairly healthy, low demand patient with just some hypothyroid. This is how she's fixed at outside facility. There's certainly some signs of a struggle here where if you look at the lateral in particular, you can kind of see she's got some changes along her anterior cortex, and there's some bone graft substitute that's been placed in the middle there. And so what I imagine happened is the outside surgeon, in trying to reduce this simple spiral, just overcompressed her osteoporotic bone and just caused multi-fragmentary breakage of her distal femur, and so created a comminuted fracture from a simple fracture. And so you can see at 6 weeks, she now has this fracture of her plate and more fragmentation. And so what we did with this patient is she went for a revision ORIF. We used a drill to try to drill into her cement mantle so we could place an intramedullary nail. The goal for this was to hopefully have some filling of her central defect and have some stability of the nail. In retrospect, probably should have tried to advance the nail a little bit further, closer to her femoral stem, but it didn't do that. And so these are her kind of post-ops that show good alignment overall and filling of the void with the nail. Around 6 months, she does have some healing. We attain these obliquogram radiographs, which are a little concerning for varus angulation and maybe bending of the plate. So we got this CT scan that on the scout shows that maybe it's not quite as much varus as the plain films would suggest. But she's having symptoms, not really wanting to walk on it. So she kind of merits a revision. So we revised her to a long, stout medial plate where we extended that very proximally, and we revised her lateral plate. We grafted her with some corticocancellous strips and had her weight bearing early on, about 2 weeks after surgery. And so here she is about 6 months out. She's healed her medial cortex. Laterally, she's still progressing. But the learning points for me on this one were really inadequate support proximally for a nail, and should have considered medial plating. I was concerned about the proximal extent of medial plate, at how high it would go, and if we would be able to get fixation on the medial side. But as we demonstrate here, you can get fairly proximal with a medial plate, so long as you're a little bit anterior. And then it raises the question is maybe we should have used Forteo or Timlos for an anabolic agent to help with some bone healing given her age. And so last thing I wanted to point out or bring up is this consideration of vascularized medial femoral condyle, which is a newer technique in hand and plastic surgery for these patients with poor bone healing. I haven't done this yet, but as I've been thinking about these cases, it's kind of come up as maybe a potential solution for these patients where you have this vascularized piece of medial femoral condyle that you're able to rotate more proximally into a defect. And so here's a case of mine where it's not quite in the distal metaphysis, but this guy has a chronic nonunion that we exchanged, nailed, and did a lateral plate, but we also did this MFC on the medial aspect. And here he is at 4 months, completely healed, which is a great outcome for him. So in summary, patient and fracture characteristics should drive the need for bone grafting versus just fixation, allowing for things to heal. Consider plate nail or dual plating for patients that need early stability, particularly in elderly patients. I think RIA and pelvic graft with some extenders are necessary for these sizable defects. And then for really osteoporotic or poor bone healers, maybe consider an anabolic agent or this vascularized MFC. Thanks.
All right, thanks, Justin. Sean, you all set? Sean, you're muted.
I think I'm all set. Can you hear me?
There you go.
All right.
Looks good.
Thanks, Hobie. Welcome, everyone. Continuing on the theme of distal femur issues, I'm going to take up a little bit about complications of after distal femoral fractures. And obviously, stiffness, infection are problematic. Dr. Haller nicely covered open fractures with associated bone loss. So I'm mainly going to focus on non-unions, and at the end, we'll look at a couple of cases of malunions. So we'll try to get back to some of the principles of non-union treatment, and specifically how it applies to distal femur fractures, and then some that healed in a suboptimal position. So in general, and I think Tamara's point, I think she shared her excellent experience over multiple years dealing with difficult distal femur fractures. And at the end of it all, I think they're more common than you think. A lot of times we use rigid implants that may mask a non-union. The published literature would suggest it may be in the range of 10 to 15%. So they definitely do occur. And just keep in mind, they're not all treated in an outside hospital. We all have these non-unions of the distal femur. Open fractures are obviously going to be the greatest source of non-unions, especially those with bone loss. Like I said, Justin covered those, so I'll try and focus on aseptic non-unions for the most part. So just some general principles. Whenever you have distal femoral non-union, obviously to determine the root cause. I don't think you can go through and establish any type of a logical treatment algorithm if you don't know why it occurred, so you don't do the same thing twice, which you see over and over. The vast majority of these, in the absence of bone loss, are due to mechanical instability. And as a result, I think a real minority of these require bone graft. Once again, different kettle if you're talking about associated bone loss. For simple patterns, really understand the plane of the non-union and figure out how you can create compression and stability. So for transverse patterns, think compression works well. We'll look at some examples. An oblique pattern, maybe you'll use a different strategy, but once again, to compress that non-union to enhance the mechanical stability without bone grafting, assuming there has not been osseous resorption. If things are rotationally unstable, think about getting multiple planes of instability. I think it's why plates around nails work for femoral shaft fractures, especially infraisthmic fractures. And I think the same applies to distal femoral non-unions. And always keep in mind, some non-unions just need a change in implant. And we'll look at kind of a case example, and I imagine Hobie, Mara, and Justin have the same experience, especially with previously plated distal femoral non-unions. So we'll start with just a quick, simple one. 68-year-old, he got sent in. I think he had a nice, whoever nailed him, I think did a nice job. He's got a nice, probably 5 or 6 degrees of valgus alignment, and he has this hypertrophic non-union. Based upon laboratory markers as well as this history, we're going with the assumption that this is an aseptic, non-mobile, he hasn't broken any screws, hypertrophic non-union. Gosh, if I could take care of non-mobile hypertrophic non-unions without deformity all day, those would be good days in the operating room, because these, you just go back to basic principles. Could you exchange nail this? Absolutely. Would it work? Probably. I think it'd have a very high success rate. Could you plate around the nail? For sure, because there's probably some micro-rotational instability that contributed to this. There's clearly a good biological response. Alternatively, I just chose to take the nail out. I just didn't want to exchange nail through his knee, but that's just a personal preference. Figuring that this was a relatively transverse, hypertrophic, aseptic, non-mobile, non-union, just provide compression. It doesn't really move. It's probably the stability that gets this to heal, and see the difference, especially look at the anterior and medial cortices in just 6 weeks. Notice that difference of that anterior cortex, 6 weeks on something that's been sitting there for 2 years. That's just the power of enhanced mechanical stability. And by 4 months, he's fully healed. Same thing, slightly different pattern. This woman got sent in, she's 61. She's rather large. It's a little over a year since she was fixed with this lateral plate. And the CT confirms a persistent oblique, that should say plain non-union. She's still aching. She's back on crutches. And so look at the problems associated with this. I think this was initially a relatively simple fracture pattern. I think they have a relatively stiff construct proximally, and then a very flexible construct in the region of a simple fracture pattern. So if we just unwind that, get back to principles, and obtain compression across this oblique non-union in order to remove that mechanical instability without bone graft, this should reliably convert to a union. And truly, if it hadn't been over a year, you could probably add lag screws to this and call it a day, and I bet that would work. But if I'm going to expose it enough to place the lag screws, I went ahead and exchanged the implant because I don't know how many cycles that implant has seen. And even notice that medial cortex, once again, in just 2 months, it goes from that persistence of the non-union medially, and in 2 months, it's virtually healed. A little bit of a different pattern. This got sent in a little over a year after being fixed. So I think a reasonable fixation construct. Right, this is a very comminuted metaphyseal fracture. I know Mara is sitting there saying nail, nail. I would not argue with that, Dr. Schenker. That would be a very good strategy for this. It was treated with a plate. Looks like good alignment, reasonable fixation construct. Now, depending upon how that non-union behaves is going to determine how I would ultimately treat that. This is what she looks like at 15 months. So a really minor deformity, I think an acceptable deformity associated with this. There's been some central resorption, so kind of a non-union with multiple different characteristics. Some bone formation medially, but resorption centrally. So to me, these are non-unions that are ideally treated with a medullary implant. So previously plated, but not with a simple plane of the non-union, I think are ideally suited for treatment with an intramedullary nail, whether it's antegrade or retrograde. I chose a retrograde nail, and in 4 months, you can already see robust healing for that. So enhanced mechanical stability, and I think all of the associated advantages of an intramedullary nail. By the way, on those first two cases treated with plates, I would allow them immediate weight bearing. Simple transverse non-union compressed and plated, let them weight bear. Oblique non-union with lag screws, if it's aseptic and non-mobile, let them weight bear. With a nail, let them weight bear. A little more complicated pattern. 30-year-old high-speed motorcycle accident. This is open. There's a little bit of bone loss, but I don't want to cross over too much into what Justin was talking about. But this is certainly a setup for a non-union. And the techniques for fixation on this one will become immediately evident and relevant. So he's got a comminuted metaphyseal distal femur, poor vascularity to this large segment, but there were some attachments to it. So we use that to really judge our length, alignment, and rotation. And so use that small plate distally just to know that we had it docked distally correctly. And then proximally, we could see where that belonged. But we know this piece is relatively avascular. He had relatively significant stiffness at 2 months, enough that I thought he needed at least a knee manipulation. And I thought, given the open nature of that, this might be one that I would almost, this is treatment of an anticipated non-union. So since we had the opportunity in the operating room, did an osteoperiosteal graft, left that relatively avascular segment in, but elevated the remaining periosteum anteriorly, and then grafted, let him be full weight bearing at 3 months based upon his articular injury. And then that fills in relatively nicely. So in the last few minutes, we'll just switch a little bit to talk about malunions associated with distal femur fractures. Most important take home is avoid it. I really think you have your golden opportunity at the time of your initial operative fixation. And so one should spend the time to make sure they have not left a patient in a poorly reduced position, because that's your best opportunity to get it correct. In order to avoid malunions, you need to understand the source of them and to anticipate what's going to be the potential problem. And I think between Justin and Mara, it was extremely well covered, some of the problematic fractures that may require a dual type fixation, whether it's a nail plate or the addition of a medial plate with a lateral plate to avoid late deflection, especially in the coronal plane, late varus failure with lateral locked implants, especially in obese patients, the elderly patients with poor bone quality, or patients with bone loss. So overall, I think it's easy to say, but it's hard to do to avoid all malunions. So we'll look at a couple of cases and we'll apply some of the basic principles that I'm sure you see at these webinars that really apply to all lower extremity malunions. And that is to recreate the proper length and correct the mechanical axis, both in the sagittal and coronal planes. So just a couple of cases, one in each plane. So we'll do a coronal plane and then a sagittal plane malunion. So this fella had a segmental femur fracture that was initially treated with an intramedullary nail. You can see they did an open approach. So perhaps there was some additional insult to the local vascular supply. Then, because I think perhaps I would implicate this screw of not allowing a relative stability construct, but I'm only hypothesizing, perhaps that led to a further delay in the overall healing. They eventually took out that screw and the other screw had broken. And after healing, he had about a 10 or 12 degree valgus malunion of the distal femur. So he only had a limb length loss due to the geometry of his extremity because it hinged on that medial sided distal femur, but he clearly has a valgus deformity. And I think you can appreciate the lateral axis deviation from that valgus deformity and a little bit of shortening associated with the geometry. So this should be relatively straightforward. We want to accurately reconstruct the mechanical axis so that he has equal weight bearing, and that will allow equal loading of our deformity correction with predictable healing. So you could treat this in a variety of ways. You could do an oblique plane osteotomy, you could do a transverse osteotomy in a nail, you could do a medial closing wedge osteotomy. In order to maintain length, I think it's very reasonable to do a lateral-based opening wedge osteotomy. You can see a clamp placed just to make sure that that medial hinge stays intact. Stacked osteotomes to open that, dial in the coronal plane, reduction, confirm it intraoperatively with something that lets you estimate the mechanical axis and consistent with the preoperative plan. Put in a femoral head allograft. Once again, a very stable construct at the end that you can let this patient weight bear on immediately because they have an intact medial hinge to that. By 6 weeks, it's already incorporated and certainly radiographically healed by 3 months, and that's him at 1 year. So now in the other plane, I think we can learn a lot from this. Getting back to avoiding malunions of the distal femur. This guy was injured 2 years ago, treated with a lateral plate. He went on to heal. They took the plate out about a year after his original injury. He's got a limb length inequality of about 2 centimeters. He obviously has quadriceps weakness and he feels that hyperextension deformity. And I think everyone can appreciate the medialization of the distal femoral segment. But then really look at the lateral x-ray and you can see how posterior that implant was originally placed. And so this is the predicted deformity that you would expect, so-called golf club deformity. So medialization of the distal articular segment, and they left him in a hyperextended position. Now, will that contribute to his 20 millimeter limb length inequality? I don't know. We'll look at him in a little more detail, but I think it certainly makes up for the rest of his symptomatology. So is this going to be a multiplanar correction or sagittal only? So interesting on him, when we get the full length standing x-rays hip to knee, then we have the chance to inquire what's going on with your right hip. So about 10 years ago, he had a femoral neck fracture that was treated in Mexico. He healed with a shortened femoral neck. So that would have given him lateral axis deviation. Then the medial displacement that occurred when they fixed his distal femur 2 years ago perfectly corrected his mechanical axis in the coronal plane. So he actually averages out. So it makes him into a pure sagittal plane deformity with some limb length inequality. So we opted to just treat the sagittal plane deformity to take care of his knee symptomatology, his hyperextension that he feels at his knee joint and the associated knee discomfort. So same principles in the metaphyseal region of the distal femur, an anterior opening wedge osteotomy, placement of a femoral head allograft, placement of a plate, let him fully weight bear. That's him at 3 months, healed, continues to remodel at 6 months. So just in summary for this component, there are a lot of other complications with distal femur fractures that we can talk about in detail, but I just wanted to focus us on a few. Non-unions, really know the cause just so you don't repeat it. come up with a new strategy based upon what you observe. It's usually a mechanical problem. Compression is your best friend. Sometimes you may need to change the overall implant strategy, especially in previously plated aseptic femoral nonunions that don't have a vigorous healing response. Malunions, get it right the first time whenever possible. If you do need to correct one, try and correct all aspects of the deformity, and we can talk about that in more detail as desired. Okay, thanks very much. Thanks, Hobie.
All right, thank you, Sean. So I see folks have had some questions, which is great. We're kind of answering them on the fly. I'm going to pull up my PowerPoint again. Now, if all the faculty could be available, microphones on, we're going to do the last part. I know we're getting close to an hour, but we have, I think, 9 cases. This is kind of rapid fire. Is this going to heal, not going to heal? And we'll kind of go through these. So for the faculty, when you recognize your case, now I think, Mara, this was one of the cases in your talk.
Yep.
Yep. So we kind of sort of know what happens with this one, right? So for folks that weren't paying attention, this is an anatomically reduced, lag screw fixation type deal here. Ultimately end up with this. So the question is, what we're going to do for all these cases, this is actually a very good one to start out with, is this going to heal or is this going to not heal? Everybody can vote and say, okay, is this going to heal or not? And then faculty can kind of discuss if they think it's going to heal, not heal, and why. And this one is perhaps a little unfair because we already know what happens. Okay, Mark. Oh. So this is one of the cases in Mara's talk. Okay, here he is at 6 weeks, 3 months, and 6 months. Now, you said he's back to running, so he's clearly like healed, although he started to fail and then kind of healed as he was failing, perhaps.
Yeah, I think that's what happened. He didn't come back for his 1 year follow-up because of, or for his 1 year follow-up after that 6 month image after I pulled that screw out because of COVID. So he, I'm not sure. He told me he was running 3 miles a day when I talked to him on the phone, but I don't have follow-up x-rays.
We might have another case where things start to fail, but the fracture still heals as you go in time. And we'll get to that one perhaps here in a second. So let's move on to the next one. So Justin, I think this is one of your cases. Ground level fall, obese, 74-year-old female, hypertension, hyperlipidemia, RLS. What's RLS, Justin?
Yeah, restless legs, nothing crazy.
Restless leg syndrome. How dreadful. Fixed like this. Here she is, 7 months post-op. Her C-reactive protein and SED rate looks good. She has normal metabolic labs and she has negative cultures. So you went in and did a little biopsy before treating this, or what'd you do?
No, so we aspirated her knee.
Yeah.
And that was negative.
Yeah, so just for fellows, I know this is probably obvious to you, but any of the plates we place on the distal femur are intra-articular. Proximal tibia is typically extra-articular. So a knee aspiration is actually a good way to kind of get a guess whether or not you think they have an infection. And it's cheap and easy to do. So intraoperatively, Justin, what do you got going here?
So removed everything. Wanted to address her medial translation varus deformity. So she got dual approaches. She got reduced with this pararticular clamp and wired, and then we placed dual implants. These are intra-op spots just to make sure we liked her overall alignment.
Yeah.
Which we did, and then we finished placing screws.
So that big medial plate is a buttress against varus collapse, yeah?
Yes.
Okay, so here we are intraoperatively at the end, and post-operatively, this is where we are. So everyone, it's time to vote. To heal or not heal, and I'll put the image back up there for you.
I thought it was going to be the first one that we were going to vote on.
Yeah. So 81% think it's going to heal and 19% think it's not going to heal. Faculty, what do you think?
Heal.
Heal?
I'll go with not heal.
Yeah, why?
Because it's stiff. And the issue with this was it was an alignment issue. It was a reduction issue to begin with. I don't think it was necessarily a biologic issue. And in this case, you're putting a very stiff implant yeah, I'm going to go with not heal for that reason. I think the implants are too stiff.
When I first saw this one, that medially based implant certainly makes a lot of sense in this one for me to correct that deformity. I think I agree with Sean. It's either stability or deformity that I think leads to most of the non-unions of these things. So let's see. 3 months post-op, she's weight bearing at 6 weeks. So she's been walking for 6 weeks, walking with a cane. We're not going to vote on this just yet. Sorry. Here she is at 6 months. What do you think is happening there, Justin?
Yeah, she's obviously changed her overall alignment. She doesn't really have too much pain in her knee. She just attributes most of her issues to balance. But certainly concerning, she sheared the head off of one of the screws and she's had a change in her alignment. So concerning, but we didn't dial up non-union surgery on her just yet because of her, lack of knee pain. But
certainly looks like she's drifting into a little varus, yeah?
Yep.
And here she is at 10 months. Broken lateral plate.
Yep. And she's escaped out the back.
Yeah.
And so I included this one because this is a good learning case for me. I don't know if you can scroll back at all, Hobie, to some of the initial intra-op. I think one aspect that's not really talked about a lot as we kind of are seeing more dual plating with medial plating is that the medial side is also a trapezoid on the distal femur. And so as we place this medial plate in kind of buttress fashion, as we closed it down, can you go to the next slide?
Next slide, forward.
Oh, sorry, forward, yeah. You can kind of see her medial plate is translated a little anteriorly and doesn't really maintain as good a buttress as, would be ideal. And so, and at the time I thought this was sufficient because it was along the anterior portion of her distal femur. But clearly it wasn't because it wasn't able to contain the distal femoral segment. So I thought that was an interesting failure and maybe something for people to think about when they're doing fixation on the medial side of the distal femur.
Sean, I'm going to go back to here where she fails at 7 months. What do you think about bone graft for this one? A lot of them you're not bone grafting. What do you think about this one?
Yeah, I probably still wouldn't bone graft this one because I have a logical reason for her initial failure. Yeah. And so I would still be very comfortable restoring that anatomy and then just going back to basics with that.
So we're going to
compress across that oblique non-union. And whether it's with dual plates, obviously, I think the medial plate's the more important of the implants on this, just given the obliquity of that fracture, for sure.
I think this is the one fracture. I don't like to medially plate that often, but I think these with kind of this low lateral escape, where they have this big medial spike up here that's very easy to buttress, is the ones that I really like to do that on, even initially.
Yep, I agree. Completely.
Okay. So we got that one. This is a 50-year-old gentleman in a motorcycle crash with an open distal femur and open proximal tibia. He's got a really bad soft tissue injury, which makes his x-rays look dreadful. He's got a total hip above. This is what he looks like in his spanning external fixator when he first came in. Antibiotic beads to start with. And then some selected CT scan cuts of his articular surface. He's got kind of a real deal, but not horrible intra-articular injury with a lot of metadiaphyseal comminution. So this is his immediate post-operative x-ray. His rotational assessment for me was difficult, especially when you have proximal tibia, distal femur, total joint above. For me, it makes the rotational assessment a little tricky, but here he is initially. So I did do a rotational CT for him because I was sure that I was wrong. And so I was planning from the get-go to go back, bone graft this, and fix his rotational malalignment, which I admit I did the first time around. So here he is. I corrected his malrotation. I did an iliac crest bone graft, but I put a new antibiotic cement spacer in there to kind of fill up some of this space. He's got such a huge void. And I only took crest from his graft from his crest. So is that going to heal or is that not going to heal? And I'll go back so you can see the picture.
Where did you graft, Hobie?
Medially. And I tried to get some posteriorly. I tried to kind of spread my iliac crest out as much as I possibly could. Okay, so 59% no heal, 41% heal. Let's see what happens. So here he is at 8 months, standing x-rays. His tibia thankfully healed. We could talk about his tibia differently. And then here he is at 1 year. Healed all around that big old block of cement, posteriorly, anteriorly, and medially. You could argue that maybe he doesn't have a lot of bone laterally, but he's water skiing and doing pretty well. This case is at least 5 or 6 years out at this point. So for me, the antibiotic cement serves as a way to kind of fill up some of that huge canal that I just couldn't possibly graft that much. Graft around the outside, let the bone heal around the outside, and he's got a pretty functional healed limb.
Hey, Hobie, question about that one. So when you're doing these, and also for Sean, because I know you guys up there will do cement spacers and just leave them in people and watch callus formation around. What drives your decision to just continue to watch it versus take it out and graft in that space?
In the cement space.
Yeah, in the cement space.
Yeah. So for me, I'm one of those people. If the bone is healing, I'm not doing anything to you. I'm not going to stop what is going well because I don't want to screw it up. So if people are healing and they're making bone, I will sit there and watch that spacer. As long as I follow them for a long period of time, they're not breaking any screws. They're back to their normal life. Things are going well. For me, there is no reason to operate on that person unless they make me do so. But that's just me.
Yeah, I'm pretty similar.
Yeah.
And that's just femurs for both of you?
Yeah, just for femurs. For tibias, I make the declaration early and just presume that a cement spacer in the tibia is going to be converted into graft or whatever technique. But on the femur, that's why I'll never bone graft before 6 weeks, because I'll get a 6-week x-ray, and if they're demonstrating a biological response, I'll let them roll with it for a while to see what happens. Whether it's a formal spacer or if they had high contamination, I use beads. Seen plenty heal around the beads.
Yep. Okay, I think Sean, you're up. So this is your 56-year-old gentleman that bought himself a motorcycle for his retirement. And he has this mangled left leg, distal femur, bicondylar plateau, a pilon, a calcaneus, his foot's avascular, no sensation distally. And this is his femur fracture.
Yeah, so the huge. So open femur with some bone loss, open bicondylar, mangled foot that eventually had to go. All right. He was kind of sick. We came back, fixed his plateau. We'll move through him. And eventually got on this distal femur.
So Sean, this is day one, just a little temporizing small thing through an open wound just to kind of give it some stability and hold it there?
I can't remember if that was day one or if that was just a couple of days later, but yeah, we did that early. Yeah, clearly it was. So at the same time, I put on the X-Fix, just to take away some of the micro motion, I think, through the open wound.
Has a guillotine amputation above this open pilon and avascular foot.
And this was kind of interesting because this has nothing to do with distal femurs, but maybe it does, because we purposefully left him with an extremely long tibia because he's got a complex knee injury. In order to rehab his knee injury with a distal femur fracture with a bicondylar, if you've got a short lever arm, right, there's no way to do a high amputation of this tibia and hope to get any knee movement. We left him with a really long guillotine amputation with the intention of then converting that later once we'd sorted everything out, 6 months or something like that.
Okay. So here's his bicondylar and then distal femur. So this is an intraoperative x-ray, yeah?
Yep, which I frequently get, especially on these where I'm not confident of the length, alignment, and rotation. So 1 point of fixation above and below, and then intraoperative x-rays confirm my alignment.
Mm-hmm. And so this bone over here is medial, and I'm assuming anterior, yeah?
Yep.
Okay.
One long sliver of bone. All right, that's intraoperatively. He was 3 bags of cement.
So finals with 3 bags of cement and no intention of bone grafting him whatsoever. Plateau.
Yeah, I'm not that excited about it. I'm going with Hobie.
So is that going to heal or not heal? Let everybody vote. Mark, are you still there putting the vote? There you go. So he's got a sliver of bone medially, 3 bags of cement in that big hole with a laterally based plate only. And he's going to be working like crazy on his motion. 58 think it's going to heal. Maybe we've converted some people, and 42 are going to say it's not going to heal. So let's see what happens. So here he is. Plateau looks great. At 5 months, he looks like this. 10 months, looks like this. A lot of cement, but he's making bone, especially along that medial side. 10 months, there's his knee joint with a very long amputation. Here's his knee range of motion. So as Sean said, you know, leaving a long tibia is going to make it easier to rehab that knee, I think, at least initially. All he needs is a parrot on his shoulder.
That's poor taste. I apologize for that.
Here he is at 17 months. We're talking JOT length follow-up at this point, 2.5 years and 5 years.
So I can either get this guy to let me convert him to a regular length BK. Our prosthetist got him fitted, and he's been pounding on this thing for 5 years. So whether it's an implant cement-based union, I don't know what you call it. I mean, he certainly formed that medial sheet of bone. I would never run him without that plate, I can tell you that. But yeah. I guess he's functionally healed.
So if his plate is symptomatic, your response to him is going to be, well, if you want me to remove that plate, I got a lot more work to do to make that femur heal, or you can live with that plate.
You got it.
Well, this plate you can see was removed, which I think is common, especially folks that have amputations. The list is quite uncomfortable around the tibia.
Agreed.
Great case. Okay, Mara, I think you're back up. So you have this 60-year-old male schizophrenic polysubstance abuser that has this 3C open injury after being struck by a car. CT goes through and kind of shows this metadiaphyseal comminution with perhaps a little bit more of a complicated joint injury. Sorry, I'll do sagittal real quick. Looking for Hoffa. Of course, the lateral side is the easier side and the medial side is the more difficult side, of course. So intraoperative x-rays, getting the joint together, getting a plate. I see some cement there in the middle. Medial approach probably to help you with the reduction, or is that all just open wound there, Mara?
That was from the vascular repair.
Vascular repair, okay. Did you use that for anything to kind of help you out?
I don't honestly think so. I think we closed with, this was 4 or 5 years ago, we closed with sutures so you didn't see them. So everything that I did was through that lateral side, but those were old vascular staples from the first night.
Yeah, but their approach tends to be kind of posterior-esque as well.
Yeah. Yep.
So here we are. 3 months later, you did a rhea bone grafting from the contralateral femur. So this was a planned, staged bone grafting procedure?
Correct.
Okay. So now the question is that going to heal or is that not going to heal? So Mara talked a lot about, man, I hate the laterally based only implants sometimes for these injuries. Is this going to heal or not? Justin, what do you think?
I'd say no. I'd worry about the lack of medial support on this one.
Excuse me. So 74% think no.
Good Lord, Hobie.
Sorry.
Cover that COVID mouth.
So we're about 75%, 25%. All right, Mara, what do you see?
So 6 weeks, 3 months, 6 months, everything looks like it's healing. I don't see any progressive hardware failure. I mean, I can be very critical of these x-rays since this was several years ago. You know, I probably would not do this fixation strategy now. And I certainly wouldn't have 2 screws so close to the fracture site because I used that initial screw to sort of meter that golf club deformity and then placed a locking screw right above that. And so I don't like that from a stiffness standpoint. But it doesn't look like he's having any progressive hardware failure, and it looks like he's going on to union.
Oh. One to watch for a while. As long as it's making bone and it's trying to heal, I watch these until they make me do something different. 15 months ambulating without an assist device.
Yep, we won on this one. I would have also probably voted for not heal, but this guy, every year I wish him a happy new year because I rang in the new year with him, I think 5 or 6 years ago.
Yeah, great case. Okay, Justin's back up. So a 64-year-old female had a ground level fall. She has CHF, MS. She's blind and has neuropathy, and she has this periprosthetic fracture. Justin, I couldn't get your CT scans to run, so I went straight to your fixation.
Okay. Yeah, CT scans just showed a pretty low fracture around that component.
So she's weight bearing as tolerated with a walker. So you're doing that immediately. You're letting her get up and walk immediately.
Yeah, given her her blindness and everything else. Yeah, we let her weight bear immediately.
Okay, everybody, is it going to heal or not heal? And you got some blocking screws there, yeah?
Mm-hmm.
Yeah. That not only helps with your alignment, but you know it helps with your stability as well. 86% think are going to heal, and 14% says no heal. 3 months post-op, weight bearing with a cane. Already got some good callus there. And 6 months without an assist device, independent, no pain, looks pretty good.
Yeah, she's still not totally healed on the lateral side, but we're seeing her back in another couple of months. But thought this was interesting use of a nail.
It's pretty interesting to see, like, you know, the debate about whether you think it's going to heal or not, and how we are still all kind of learning what's going to work, what's not going to work. And sometimes we're surprised by these things. Yeah. This is another one of Sean's. 26-year-old person in a motor vehicle crash, polytrauma, initially treated at the outside hospital with an irrigation and debridement, although it was somewhat limited through a lateral approach. X-fix antibiotic beads. They remove some bone, but you never know how much. And then at 2 weeks, it shows up to you, and this is what it looks like. In the external fixator and some beads, perhaps not reduced as well as we'd like in an external fixator. So it looks like they revised the X-fix. He's now 3 weeks out. And now clear. Does that mean healthier, Sean?
Pardon me?
He says is now clear, like clear for a real procedure?
Yeah,
or?
now he's cleared. He got sent over in about 2 weeks. We stretched him, and now he can undergo a definitive operative fixation.
Yeah.
But we don't have to do heal, not heal. We did not treat him in an X-fix.
Right. And, you know, see, folks, I just want everybody to notice that he still looks like he's still pretty short here. And at, you know, 2 weeks, it's difficult to get that length back. So do this initially to the best of your ability, because getting that length at 3 weeks is tough.
Yeah, that was a little disheartening.
Yeah.
We did a lateral approach, and it looked like a big chicken bone. My man likes a little meth, so he doesn't seem like on the surface like he's a perfect host to have a completely devitalized femur. Yeah.
So here we are clamping, fixing some kind of non-displaced fracture fragments that we see there probably.
No, if you go back, he had this long, it was basically his linea aspera. If you go back to maybe the 3Ds, that long spike, if you can see, actually had maybe a tiny bit of vascularity to it, but I completed the assault.
Okay, so here we are fixing that, fixing the joint, putting this together. So here we are at the end. Some antibiotic beads still in there. Is that femur going to heal or not heal? It's a great case. $60 says, so 2/3 no heal, 1/3 says it's going to heal.
I completely agree with the no heal.
Yeah.
I thought there wasn't a shot in hell, and I think our teaching point here is do meth. I saw this guy back one time, but by 8 weeks, he'd already formed almost like an involucrum around that avascular segment and had spanning bone. And I can't imagine anyone else in the Pacific Northwest hanging on to him. So I doubt he went someplace else for a non-union repair. So I'm going with the presumption that he healed based upon how much healing. He was already full weight bearing at 8 weeks, not what he was supposed to be doing. I was a little surprised.
Yeah. It's pretty amazing how sometimes the femur can surprise you and for one reason or another, take off and heal when it looks like it shouldn't. Okay, so this is a 79-year-old female. I think we just have 2 cases left, so hang in there. Fall from standing, periprosthetic femur fracture. Get a good look at the x-rays. Intraoperative alignment films again. I think these are great. I think it's very helpful to understand what you're doing. And then here we are fixed. Notice there's a kind of somewhat of a lag screw trying to pull this medial fracture fragment in, Sean. Yeah?
Yep.
Rather than using a plate, you're just using a screw to try to pull that fragment in and make it participate.
Yeah, and I never know if that confuses the bone or not.
Yeah. So is that fracture going to heal or not heal? I'm going to go with heal. I think maybe pulling that fragment in is going to help you bridge bone across there maybe a little bit easier, even though it's not anatomic. Justin, what do you think?
I'm going to say not heal because Sean already showed 2 cases where I thought it was never going to heal. And then this is a much simpler case that you would think would heal, but I'm going to guess it's not going to heal because he wouldn't include it otherwise.
Yeah. This is the difficult part about the distal femur. So there we are at 3 months. Looks like we're forming some callus. Here we are at 9 months, looking pretty sweet. Sean, what do you think? Do you let folks weight bear on these immediately?
You know, in elderly patients, I think that's our job, but no, I don't always. And I hate to say it, it depends. I mean, I think that's what we should be doing. And I can't remember what I did on this elderly woman.
Yeah.
But I thought she was interesting because we argue even amongst ourselves, you know, is it, if you're going to bridge, do you need to maintain a pure bridge plate construct? Or if you think you've got adequate surface area, but too much displacement without making it too rigid, so not putting in multiple points of fixation, but bringing it a little more into the ballpark, is that a good thing? I don't have the answer, but you can see my general feeling for this pattern.
I think it certainly worked out here. Okay, I think this is our last one. So this is one of mine. This is a 46-year-old gentleman injected in a motor vehicle crash with this wonderful tibia distal femur combo. This is what he looks like after his debridement and external fixate replacement. So he's lost a fair amount of bone, and he's got this complex distal or proximal tibia to go with it. So here he is on post-op day 1. So he's got this antibiotic cement spacer. He's got this medial fragment that I did not try to capture and pull in, like Sean just showed, and we fixed his plateau. So is this fracture going to heal or not heal? Just by itself without doing anything else? 60-40, 60% say not heal. So what do you guys think about non-locking screws in the shaft? I'm one of those people that I try to use non-locking screws in the shaft when I have good bone for the most part. What do you guys think about that? Because a lot of folks, you know, use all locking in the shaft. Some people use a combination thereof. This is all non-locking in the shaft, and that's bridging quite a large area with only 3 screws. Am I stupid?
No, I think you're good. Good bone quality.
Yeah.
No, I do the same thing. I try to stay away from locking screws in the diaphysis.
Yeah.
I do the same thing. My indication for using locking screws in the diaphysis is when I feel like I'm translating the shaft to create a golf club deformity. I'll sort of meter it in with the cortical screw and then place the locking screw to sort of lock it down.
Yeah. Yeah, so I work hard. I typically put in a non-locking screw in the distal fragment first and really try to get the plate down on the bone, so that I try not to do that. It doesn't always work out, but that's what I try to do. So here he is at 6 weeks. He's making a little bit of callus. He's got this big cement spacer, and I was thinking initially I'm going to come back and bone graft this for sure. Here he is at somewhere between 10 and 12 weeks, still making callus, making a little healing bone. He's not really hurting that much. I'm letting him start walking on it. And here he is at 4 months. Now, this guy is like an iron worker. He's on his feet like 14 hours a day, and he wants to go back to work. He's not having any pain. He's walking. He's not failed any of his fixation. He's making healing bone. So I'm like, fine, go back to work. Here he is at 10 months. Now, at 10 months, this screw is broken and this screw is broken. So he's got 2 broken screws in the diaphysis. There's one hanging on for dear life. And he still makes a little bit more bone every single time I see him. He's working 10 or 12 hours a day. And the question is that going to go on to heal, or is that going to fail? We'll let all the participants vote, and then you guys tell me what you think. Because I'm sitting here looking at this going, oh, God, he's got 1 screw left. 85% think he's going to go on to heal, and 15% think he's not. What do you guys think? Is that going to make it?
That 1 screw's working hard.
Yeah, yeah. Justin, is it going to fail or is it going to heal?
I think he's going to make it.
Who would do something now? Mara, would you do anything with him now?
No, I'd watch him. I think there's a chance he might pop that last screw, and I think he's going to heal.
Yeah.
Yeah, if he's not hurting, I would just leave him alone.
Yeah. Sean?
Yeah, I might. Just since he only has 1 point of fixation proximally, and if at best I think he's going to have an implant-dependent union, I might just add a couple of screws to the proximal segment, add a couple non-locking screws just to give them a little more durability. That would be the only thing. I wouldn't go full meal deal and start popping out cement and putting in retrograde nails and stuff.
That makes a lot of sense. I watched it because he's working so many hours a day. I'm like, come on, man, that's got to be healed. So here he is 17 months out, still with only that one screw. He has no pain. He works like crazy and he's doing fine. So my take home from that one is, and I think from a lot of these distal femurs is, sometimes a defect will still heal in the distal femur. And there's this race between it healing and your fixation failure. And at least for me, as long as they're making bone, they're healing, they're not symptomatic, I wait it out. I let them prove to me that they need another operation before I do anything. However, I think Sean's idea of maybe putting in 2 more screws somewhere else in the diaphysis for that one may have been a good idea. But that's our last case. So in summary, I hope everyone had a good time with this webinar. Just identify your options available for managing these fractures. There are lots of options. There's lots of different ways to treat these, but understand the implications of your reduction and your stability and how it's related to these common failure mechanisms. And then describe the various ways that implants can be used to affect your stability, healing, and your complications. And that, ladies and gentlemen, is all I have.